Hi, everybody. Thank you for joining us tonight's webinar hosted by the Turkish Society of Fertility Preservation. My name is Aydin Perinçi. I am a professor of obstetrics and gynecology at American Hospital, Istanbul, Turkey. And I'm one of the board members of the Turkish Society of Fertility Preservation. I'm going to moderate tonight's webinar, and my guest is Dr. Martin Hirsch from United Kingdom, who is going to talk about fertility preservation for women with ovarian endometriosis. Dr. Martin Hirsch is a consultant gynecologist and endometriosis specialist at Oxford's John Radcliffe Hospital in the United Kingdom. He works as a full-time gynecologic surgeon, specializing in excision surgery for people with endometriosis. Martin was awarded a postgraduate medical doctorate research degree from Queen Mary University of London and has published widely in the area of endometriosis, including fertility preservation. He has received national recognition awards from NHS Improvement, the British Society of Gynecological Endoscopy, and Health Education England. He is the current chair of the British Society of Gynecologic Endoscopy, Thoracic Endometriosis Working Party, and is senior council member managing awards and bursaries. Thank you, Martin, for accepting our invitation for this webinar, and the stage is yours.
Thank you so much for having me. Like I said, I'm coming to this presentation from a surgical perspective as a full-time gynecological surgeon. I haven't worked in reproductive medicine for since kind of 2014-15. So I'd be really interested to hear any perspectives from reproductive medical experts that are watching or yourself afterwards. Without much further ado, I'll go on to my presentation and welcome any comments in the chat box and discussions afterwards.
Okay, thanks.
So we're on screen share. Can I check that you can see everything okay?
Yes, we see it.
Fantastic. So again, pleased to meet you. My name is Martin Hirsch. I work at Oxford University Hospitals. I'm an honorary fellow of Oxford University, and I'm a senior council member of the British Society for Gynecological Endoscopy. Tonight's presentation will be on the role of fertility preservation for women with ovarian endometriosis. So my only conflicts of interest are that I am a council member for the British Society of Gynecological Endoscopy, and I have no financial conflicts to declare. So the objectives of this talk today are to discuss a little bit about ovarian endometriosis, what it is, ovarian reserve testing, the benefits perhaps of fertility preservation, the fertility preservation guidelines, criteria for fertility preservation, future thoughts. So why is this important? Well, let's take a view from the United Kingdom, perhaps. You know, there are over 11 million people of reproductive age. 5% of these, let's say, will have endometriosis. And that's a kind of an underestimate, with some estimates being as high as 10%. Of these, perhaps up to 44% will have ovarian disease. And the important thing is, who do we treat and how do we treat these patients? Patients will present at various ages during their reproductive lifetime. So a little bit about ovarian endometriosis, and I'll play this video while I talk. The theories of ovarian endometriosis include different possibilities of endometriosis implanting on the ovary and invaginating, or endometriosis as peritoneal deposits that cause adhesions to the ovary and then almost enclose an area that causes what's called a pseudocyst. In this scenario here, we can see an extremely large ovarian endometrioma on the right that's been drained in the first of a two-stage procedure. This procedure was done ahead of fertility preservation, as this patient's AMH was low at 5. And so you cannot see the left ovarian fossa at all, as everything was obliterated with the rectosigmoid mesentery adherent to the left ovarian fossa. And just through that window, you can just about, with the eye of faith, see the left ovary surrounded by a blocked and swollen fallopian tube. So this patient is going on for fertility preservation ahead of a second stage procedure to treat her ovarian endometrioma. So we're going to we're going to take things back before going forward. It's a slight kind of strange way of doing things, but I thought it's worth us thinking about what do the guidelines say first, before then going on to having a think about why the guidelines say what they say. So there are 3 guidelines that I principally draw upon when I'm thinking about managing ovarian endometriosis here in the UK. The first of these is the NICE guideline for endometriosis, published here in the UK and freely available to anyone that wants to find it online. And certainly this QR code will take you directly to that. Second guideline would be the ESHRE guideline, recently published in 2022, with the chair of that being my close colleague Christian Becker. And then the ESHRE guideline for female fertility preservation. And we'll touch upon all these 3 guidelines. But first of all, the endometriosis guideline. When talking about the surgical management of endometriosis, of ovarian endometriosis, the guideline suggests considering excision rather than ablation to treat endometriomas, and importantly, taking into account a woman's desire for fertility and her ovarian reserve. There are no specifics about the criteria for testing and the criteria for intervention, but it certainly is a step in the right direction for thinking about someone's reproductive rights in the future or present. Where fertility is a priority, it does suggest thinking about laparoscopic ovarian cystectomy, as this enhances spontaneous pregnancy and reduces recurrence. But again, it heeds caution and suggests that we need to take into account patients' ovarian reserve. And we'll go on to the rationale why in a little bit. But I think it's important to note that the guidelines aren't always able to provide every single caveat. And in this circumstance where it says fertility is a priority, we need to think that fertility is not a binary factor. It's something that a person may not be concerned about when they're 21, but then very concerned about when they're 31. And it's an entity that women possess from menarche and that grows in importance over time, and that needs to be considered at every single stage when someone's seen and presenting with ovarian endometriosis, because while it may not be a priority at that moment in time, it may be of vital importance later on. We don't want to provide permanent interventions that cause a detrimental effect to their desires at a later stage. So thinking about ovarian reserve testing and the guidance from the ESHRE female fertility preservation, they suggest that patients with severe endometriosis, particularly bilateral endometriomas, are at higher risk of premature ovarian insufficiency following surgery or with the nature of their disease. And following surgery, that risk is thought to be about 1.5% to 2%. They're thought to have lower AMH levels inherently, and surgical treatment can further impact that ovarian reserve. So the recommendation made by the ESHRE guidelines are that the relevance of ovarian testing to help guide fertility preservations or treatment options in endometriosis patients remains inconclusive. And that's based on a weak body of evidence. So how is this relevant to future fertility preservation? Again, ESHRE conclude that the relevance of the pre-treatment AMH levels to predict the chance of future pregnancy or the need for fertility preservation is unclear, as studies reporting on this have made conflicting conclusions. The recommendation are that clinicians need to be aware that in patients with endometriosis, the involvement of the ovaries and certainly the radicality of surgery have a direct influence on the ovarian reserve, as measured by some surrogate markers such as AMH. But its relevance to future fertility is unclear. And that's an important discussion point that I certainly have with my patients, as certainly surrogate markers and reductions in ovarian reserve don't always correlate with someone's ability to fall pregnant spontaneously in the future. And often the discussions that you're having about fertility preservation are in the context of someone never having tried to fall pregnant in the past. And with fertility and fertility preservation certainly comes health-related anxiety and potentially health-related reassurance. Someone saying, I've had my eggs frozen, so I'm okay. And we'll need to come on to this in a little bit. So now looking at the ESHRE guideline for endometriosis published in 2022. Again, it makes a cautious statement that oocyte cryopreservation is expensive, exposes women to some clinical risks, and there are many questions, including the cost effectiveness, that remain unanswered. This currently has insufficient data to support its use for all women with endometriosis. And the recommendation being, in cases of extensive ovarian endometriosis, clinicians need to discuss the pros and the cons. And to be able to discuss the pros and the cons, you need to have insight, you need to have knowledge, and you need to have, hopefully close colleagues to be able to discuss patients with if you are a specialist in pain or if you're a specialist in fertility on the other side. And the true benefit of fertility preservation remains unknown. So if we think a little bit about ovarian reserve testing, this slide highlights that the AMH is reduced in patients with endometrioma compared to endometriosis and no endometrioma. So perhaps it's inherent to the disease itself. When compared to healthy ovaries in this slide, control patients, healthy ovaries and control patients, the AMH is again reduced. Comparing endometrioma to endometriosis and no endometrioma, other cysts as well, then healthy controls show that across the board, the AMH is reduced amongst those patients with endometrioma compared to either a benign cyst, endometriosis and no endometrioma, or healthy controls. So again, further studies and prospective longitudinal studies highlight that surrogate markers such as AMH decline with time. The sheer presence of endometrioma can result in a reduction in AMH as seen here. Age is comparable. Serum AMH at recruitment is significantly less amongst those with endometrioma. But the percentage decline over time is significantly greater associated with endometrioma compared to control patients. And if you can see through this kind of sea of lines that you have here in front of you, which all represent patient AMHs at time point 1 and time point 6 months, there is a downward trend seen amongst those red lines, which represent untreated endometriomas. Again, a further study which highlights the role of endometrioma itself as a detrimental effect on having a detrimental effect on AMH, with a systematic review and meta-analysis suggesting that endometriosis just by itself will reduce someone's AMH. But again, the question arises, is AMH the best marker to assess ovarian response in women with endometrioma? In this prospective study evaluating response to controlled ovarian stimulation, the oocyte yield is significantly reduced amongst those with endometrioma compared to those with no endometrioma. When thinking about the association of this as a surrogate marker to help predict this, neither AMH nor FSH were significantly different. However, antral follicle count was the strongest predictor, which adds the thought that perhaps antral follicle count should be perhaps a more commonly used marker for prediction of ovarian response for those patients with endometrioma. So the mere presence of endometrioma results in reduced surrogate markers of ovarian reserve. But does this mean that surgery is the answer to help these patients? I think we'll all be aware that the answer is not black and white. It's not yes or no, but a careful balance between enhancing potentially spontaneous conception and pain improvement needs to be cautiously balanced against the risk of cortical loss, with over 97% of specimens removed at the time of ovarian cystectomy containing ovarian parenchyma. And this appears to increase with increasing ovarian volume and increasing cyst size seen here. We can see that ovarian parenchymal loss is associated with the majority of cystectomies, but does this translate to a reduction in the surrogate markers that we've discussed previously? And this study highlights the reduction in AMH that's seen following surgery, with a nice meta-analysis done by Rafi et al. But what are the parameters that we want to assess to highlight those patients that are more at risk than others? Are there specific features associated with a greater reduction? And we see here in this really nicely presented slide that features associated with a lower starting AMH include age and bilaterality. But the decline in fertility is similar, but I hope I can persuade you to see that perhaps the loss or reduction that is seen in AMH is greater amongst those young people, greater amongst those people with bilateral and multiple large cysts. So we have lots of different parameters that can perhaps be an influence to those people with endometrioma, and that can expose someone to greater risk of reducing these surrogate markers. Again, does size matter? This trial would suggest that increasing size, seen here on the right as I'm looking at it, or the size greater than 5 centimeters, poses an increased risk of ovarian cortical loss and percentage reduction in AMH levels. And this slide nicely shows the relationship between preoperative AMH levels and postoperative AMH that's associated with the size of the ovarian lesion. So we've been accurately able to determine that AMH reduces following surgery. AMH reduces following surgery with increasing size of ovarian endometrioma and with bilaterality of ovarian lesions. But if we need to operate, are there specific techniques that we should or shouldn't be using to avoid this decline in AMH? And this review, published in the Journal of Minimally Invasive Gynecology, nicely demonstrates the deleterious effect of bipolar cautery on AMH levels after surgery. With recent guidance from here suggesting that management of endometrioma should be cautious, sparing of bipolar, and perhaps should use sutures rather than electrocautery. And this Cochrane review is of limited sample size, but again, let's remember it only includes the highest quality data. Looks at live or clinical pregnancy rates, following ART with or without surgery for endometriomas prior. This shows that there's no significant difference between the two, leading us to think that perhaps this may be the same for fertility preservation. So how does this all relate to fertility preservation? With increasing age, we see reductions in almost all the variables assessed. There's a reduction in antral follicle count, oocytes per cycle, clinical pregnancy rate, and cumulative live birth rate. When this data is sub-analyzed, progressive reductions are seen in antral follicle count, oocytes per cycle, but importantly not the cumulative live birth rate associated with either no surgery, unilateral surgery, or bilateral surgery. But further sub-analyses looking at age show a reduction in the oocytes per cycle is seen greater, but there's a greater effect in the younger age group that have surgery. And this may reflect a degree of clinical heterogeneity in younger patients with more complex or more severe disease seeking fertility preservation earlier. We must note this is an observational study and not a randomized controlled trial. The largest difference in cumulative live birth rate is seen between the age groups, both under 35 and over 35, but also the difference between the younger group that's had surgery and hasn't had surgery, with a reduction from a cumulative live birth rate of over 70% to just over 50%. Again, same slide, I apologize. But when we take a deeper dive into the crude numbers, the answers patients want to know is how many oocytes will they need for a pregnancy? We commonly quote a 20-80 rule with around an 80% cumulative live birth rate associated with 20 oocytes. And there are no significant differences when looking at cumulative live birth rate according to the number of oocytes used amongst those under 35 on the left and over 35 on the right that have had surgery and that haven't had surgery. Again, a reduction in oocytes is seen with greater effect in the younger age group. And this may reflect the clinical heterogeneity that I mentioned earlier, with younger patients with more complex and severe disease seeking fertility preservation earlier. The probability of live birth increases as the number of oocytes used increases, which is what we'd expect to see. So what we understand so far, AMH and AFC appear to be the best surrogate markers for ovarian reserve. Surrogate markers are reduced with endometriomas. Surrogate markers are reduced with surgery, and these appear to have a greater impact on younger patients, those with larger cysts, bilateral cysts, and the oocyte retrieved per cycle following surgery and with age. They fall following surgery and with age. The cumulative live birth rate, apologies, cumulative live birth rate per oocyte used is equal between those with and without surgery. So the key principles that we need to think about here. We need to consider ovarian reserve before we're thinking about any kinds of surgery, particularly with ovarian endometrioma, particularly with those that perhaps are nulliparous, perhaps those with larger ovarian cysts. If we are to offer surgery, we need to consider techniques to minimize trauma to the ovarian cortex that can reduce their surrogate markers, either AMH or AFC, which in turn appear to be associated with lower oocyte yield. We need to provide individualized care. And this is on a person-by-person basis, depending on their desires, both in the current time and future. So to summarize, fertility preservation has limited data to guide specific criteria for use. We need to take an individualized approach to care. We need to have fertility preservation in the forefront of our minds as a discussion point. And it's not a panacea. It's not the cure to all. It's likely to have benefit for younger patients with large bilateral endometrioma. And a major question that we're needing to have here in the UK in a publicly funded health system, is this something that should be publicly funded? These are all questions that are going to be asked as we go forward. If there are any questions, I'd welcome them through on the chat or live. And I'd like to thank you for having me on and talking about ovarian preservation today. Fertility preservation.
Thank you, Martin. Do you hear me?
I do, yeah. Thank you so much.
Yes. Okay, thank you for the great talk. Okay, so first question is from me. I want to ask. I want to ask you by going on patient scenarios. For example, if you see a patient, a 19-year-old patient with a unilateral 7-centimeter endometrioma, how would you consult this patient regarding fertility preservation, or how she's asking what should I do?
So I think it's important to make sure we have all the facts before we start. So assessment of ovarian reserve with antral follicle count and AMH is really important off any hormonal treatments. It depends on also on the pain scenario that the patient's presented. I more commonly see patients with pain, so they often present with pain to me and they want a treatment for their pain. And for a large endometrioma, that does commonly lead towards a discussion about surgery if hormonal treatments are not successful. We then need to think about what their AMH and what their markers of ovarian reserve are like. And certainly if they have a reduced ovarian reserve, I would counsel them towards thinking or considering fertility preservation within the context of whether that surrounds having that done at the time or around the time of ovarian cyst drainage to be facilitated. And I'd be guided to an extent by my fertility colleagues. Some of them wish for drainage of the ovarian cyst before immediate stimulation. Particularly, so if this patient was not in a position to go ahead with fertility preservation, because in the United Kingdom, the majority of fertility preservation is privately funded. It's expensive. So if the person was not in a position to go ahead with fertility preservation, I'd take the more cautious approach to treating them, particularly if they were nulliparous and they had future fertility desires. And if we were talking about surgery, I'd think about a 2-stage procedure, which I commonly do for ovarian cysts over 6 centimeters, where you drain the first cyst, drain the cyst initially, down-regulate them with gonadotropin-releasing hormone agonists for 2 to 3 months, before then going back to perform an ovarian cystectomy. You'd hope in that period of time the cyst would have shrunk, so you'd have reduced the ovarian size or the ovarian cyst size. So in theory, you hope to reduce the amount of cortical loss that you're going to be induced through surgery. There will be some loss, but you hope to reduce that by shrinking the ovary and shrinking the ovarian cyst. A balance needs to be had between the use of gonadotropin-releasing hormone agonists, which can distort that tissue plane between the ovarian cyst and the cortex, but also stripping a large ovarian endometrioma that can result in greater cortical loss.
If this patient doesn't have any symptoms like pain or nothing, she just learned that she had an endometrioma, would you consider the surgery again?
So yeah, we tend not to think about surgery in the absence of any symptoms, which I think is really important. But it also needs to be considered as to whether or not fertility preservation is something she's going to go through with. So if she had an asymptomatic endometrioma, but she had a low AMH, for example, and she'd consulted one of my fertility specialists who said, I think you should think about fertility preservation, then commonly we think or look to drain these ovarian cysts ahead of fertility preservation or egg collection, stimulation and collection.
If her ovarian reserve is not low but maybe average, based on her age, maybe we can just suggest her to follow the yearly AMH follow-up.
I think that's very reasonable, and I guess there's a balance between offering hormonal medication to try and reduce the progression, but that then limits the applicability of AMH, and they'd need to come off the hormonal contraceptive treatment, for example, to then have an AMH in a year's time. Certainly monitoring or screening to continue to measure the size of the endometrioma is important, as well as monitoring of the AMH value. I agree.
Yes. And okay, are there any questions? Just so you in your talk you said it will be reasonable because the guidelines suggest that it's reasonable to do the excision rather than just drainage and coagulation because it increases the chance of spontaneous pregnancy.
Agree. And I guess the operation needs to be determined about what the next steps are or what the goals are. So if the patient wants to improve pain, they have a normal or above average AMH level, then certainly an ovarian cystectomy appears like a reasonable treatment choice, particularly in a young patient. That needs to be considered as to the most cautious treatment choice that you can offer. And what I tend to prefer is that two-stage approach if they have large endometriomas, so 6 centimeters and above. I tend to think about drainage and then down regulation before cystectomy. Cystectomy hopefully minimizes the risk of recurrence or persistence of the cyst. And we need to remember, as demonstrated in the presentation tonight, that the sheer presence of an endometrioma can be detrimental to the function and the ovarian reserve. So there needs to be a balance had between the risks of surgery as well as the risks of leaving the endometrioma in place.
Yes, you're right. Well, what do you think about ovarian cryopreservation?
Ovarian tissue cryopreservation, I'm not sure it's been studied in the area of endometriosis. It's certainly looked at widely here in Oxford for oncological reasons, but I've not seen much data on its use in the endometriosis sector. But there was a lovely article in the newspaper this weekend about in the UK here about a patient who had an oophorectomy ahead of treatment for a malignancy before then reimplantation of some of this ovarian tissue before achieving a healthy pregnancy. So I think there are roles. I'm not sure of the role of ovarian tissue cryopreservation for endometriosis, but it's certainly something to think about.
Okay.
And is the practice of fertility preservation something that's purely private in Turkey, or
Yes.
are there publicly funded opportunities as well?
No, it's not publicly funded. It's totally private. So but it's cheaper than other countries like
Sure.
United Kingdom. We have patients coming from United Kingdom
Yep.
and other countries because it's way cheaper than other countries.
And do you partner with satellite clinics in the United Kingdom that do the stimulation, and then just immediately before oocyte retrieval they fly to Turkey, or is the entire process done in Turkey?
I have some patients coming from United Kingdom. They're usually very low patients with very low ovarian reserve because they usually complain about not um, not going not finding a physician who can preserve their eggs
Okay.
because their ovarian reserve is so low. So they just fly and come, and then just we just do the retrieval for 1 or 2 eggs.
Okay.
I have some patients like this because oocyte cryopreservation is only allowed in Turkey for patients with low ovarian reserve
Okay.
or with a family history of early menopause. Other than this, we cannot
Privately.
do social egg freezing. Yes.
So you can't just do social egg freezing for those patients that want it.
No, but we can do for cancer, for endometriosis, or
Okay.
for patients who has gonadotoxic therapies.
Sure.
But we cannot do just social egg freezing.
Oh, it's interesting.
Yeah.
That's quite heavily governed.
Yeah. Yes.
It's interesting because in the United Kingdom, from what I understand, that social egg freezing out of personal choice, someone wanting to delay when they conceive, uh, is, I think, one of the most common forms of fertility preservation.
Yes. Yes. It's the most common form of fertility preservation, but in Turkey we can only do it for patients with low ovarian reserve and a family history of early menopause. Yeah. So the patients who we did the cryopreservation is with high or normal ovarian reserve is the ones that has a family history.
Yes. Okay.
Yeah.
A family history of premature ovarian insufficiency,
Yes. Or early menopause.
early menopause. Okay.
Yeah.
And they're often, I guess, good responders by the time that when they're seeing you, but perhaps they're going to be going through the menopause at an earlier stage than they'd like to desire. So,
Yes.
and what do you counsel about, or what's your target in terms of oocyte yield?
So it because we usually don't do egg freezing to patients with normal or high ovarian reserve. We
Okay.
usually um, our patients have low ovarian reserve, so we just based on their age, and
Yeah.
usually they're older than 36,
Yeah.
40s or more than 40s. We just try to retrieve what we can, and
Done.
even if even if I tell them, for example, if they're or lower than 35, we just even if you consider telling them you have to at least freeze 15 eggs, for example, but if they have 2 eggs for each cycle, they can only
Yeah.
cryopreserve like 10 eggs
Okay.
if they do 5 cycles.
Yeah.
So we did a multi-center study, and the average mature oocyte cryopreserved was like 4 or 5
Okay.
for each patient.
Wow. Okay.
So that's our patient population.
Yeah.
Yeah. So I just tell them just freeze as much as possible.
Yeah. And so with 4 or 5 oocytes, the cumulative live birth rate is, looking at the data that's published by Kobo, is maybe around 10%.
Yeah, it was 17%. We in our study it was like 17%
Yeah.
because we also we can We also did a study, uh, just checking whether the patients who had undergone egg freezing had regret or not.
Yeah.
So even if they cryopreserved low number of eggs, they had very, very low regrets. They were all satisfied that they did the egg
Okay.
freezing process.
They were pleased. And I think
Yes, they
that
were.
it's partly about empowerment and choice. I think being able to offer people the choice of egg freezing is something that's relatively new. And particularly as many more women in the United Kingdom, and I'm sure it may be the case in Turkey, are wanting to delay conception to a later age, the option for fertility preservation becomes a lot more attractive.
Yes.
And enabling that choice is something that I think is something I hope will come into the National Health Service here and be publicly funded. But we need to have a closer look at what specific criteria are going to be implemented to decide who should have fertility preservation on the National Health Service or who shouldn't. At the moment, it is purely just those people with gonadotoxic treatments, normally for oncology purposes. But I think there may be moves in the future, and I hope this is the case, that endometriosis will be covered in that, particularly when you appreciate that surgical treatments can be gonadotoxic.
Yes, yes, of course. Uh, we have one more question, Martin.
Yeah.
Does oocyte quality worsen with the degree of endometriosis in your clinical practice?
So again, I'll need to come at this from someone that's principally a gynecological surgeon, not a reproductive medical specialist. But my understanding of the data is that oocyte quality does not change with increasing severity. But I'd appreciate it. Any comments from anyone that's in the audience or yourself, if you have more experience with reproductive medicine. Again, it's been since 2015 since I was at a fertility unit, so I don't recall that it was. And my recollection of the data is that live birth rates are comparable across the degrees of severity of endometriosis, and it's more dependent on the number of oocytes that are yielded rather than there being a difference in quality.
Yes, as far as I know, the oocyte quality doesn't change
No.
with the degree of endometriosis.
And how would you treat, going back to you, perhaps the patient with the 19-year-old with a 7-centimeter endometrioma in your local practice? Is it something where you'd monitor them if they were asymptomatic? Would you routinely do assess markers of ovarian reserve if they were wanting surgery? Or would ovarian reserve testing only be for those patients that were perhaps a little bit older?
No, especially in young patients, if they don't have any intercourse, it's difficult to do a transvaginal ultrasound, and also with endometriosis, it's difficult to assess the ovarian reserve with abdominal ultrasound.
Agree.
So we usually I usually prefer rectal ultrasound, but if the patient doesn't want to do it, then I cannot assess the ovarian reserve, and I do want to assess it. So I usually order AMH, and I usually want to order AMH because I want the patient to have a document in hand.
Yeah.
To see it, because they don't understand when you say your ovarian reserve might be low according to my ultrasound, but when they see it in a document saying that their AMH level is, for example, 1 nanogram, and it's low based on their age, they just Google it and then they find out that their ovarian reserve is low. So they understand that, oh, there's something wrong because I'm young, so um, my ovarian reserve is low. That's why I usually want to see the patients. I want to order AMH for these patients, and I want them to see. Especially, I want to see AMH in from every patient with endometriosis, for follow up and for the patient to be aware of their ovarian reserve. And I would recommend oral contraceptive pills
Yeah.
to a patient with ovarian endometrioma at age 19, and recommend her to follow up. As you said, AMH might be like, I think it might be 25% lower when you're using oral contraceptive pill.
Yeah.
Just being aware of this, I can just follow her AMH,
Okay.
yearly follow up, and if it's low, so I would recommend her to just stop the oral contraceptive pill for 2 months and then just reassess with AMH again, for example, and then just suggest her oocyte cryopreservation if her AMH level is going down. But of course, it will take years, but she will be aware of her disease and ovarian reserve, and maybe she won't wait until like her 30s or 40s to have her eggs frozen.
True.
Okay, we have another question. Does oocyte quality oh no, we just did this question. Okay. Yes,
Uh,
okay.
it's really important, and I think providing patients with that knowledge and information enables them to make their reproductive choices for themselves. And at no stage would I say your ovarian reserve is low, so you should go and have a baby now because it will get less. I would not say that, but telling someone that their ovarian reserve is low, giving them the ability to make their own decisions with their reproductive health is very important, and that's something that I do try to offer, to provide information, to provide choice, and then to allow patient principally to be the decision maker in the dynamic between myself and the patient.
Yes, and I think it's also important to consider the family size and just remind the patients or the couples,
Yeah,
uh, and ask the question, how many children do you want?
exactly.
Because yeah, we usually just make the talk of just having the first baby, and then the rest, even the doctors or the couples doesn't think. But after years, they come again, and then their ovarian reserve got very low, and they just regret that they didn't talk about this uh, when they want to have 2 or 3 children.
And I think it's when I was mentioning it in the beginning of my talk today, I think it's really important that we're having these conversations with patients when they're perhaps not in their reproductive stage of their life. When they're perhaps in their early 20s, they're not thinking about a pregnancy, but it's
Yes.
important to be thinking about it, and important to make sure that they are aware of the decisions that they're making. It's very simple to say, yes, oh, let's do a bilateral ovarian cystectomy, because this person is young and this person isn't thinking about fertility at the moment. But if you do a bilateral ovarian cystectomy on someone that has a low AMH already, you can be pushing them towards a very low AMH that can be permanent and potentially irreversible in the future. So as surgeons, we really need to be cognizant and aware that our interventions can have permanent irreversible damage, which is where having that kind of multidisciplinary team working with fertility specialists, as well as working with our patients to make sure that they are fully aware and fully understanding of the risks of all the procedures that they're going through.
And how do you manage patients with deep endometriosis?
I
So
guess it's
would you
a
consider
priority.
surgery for fertility in those patients, or you just do the surgery if they only have symptoms like pain or?
So I tend to have a two-stage approach to this, in that I find out, if their priority is fertility and their pain is reasonably well controlled, I tend to move towards reproductive medicine, ART, including IVF, for example, as the first line approach. If their ovaries are not accessible, or they have large endometrioma, or they have blocked and swollen fallopian tubes, I would consider perhaps minor surgery in conjunction or with advice from the fertility specialist, a salpingectomy or tubal clipping ahead of them going ahead with fertility treatment. But for some people, it's not affordable, or for some people, it's not an option. They never want to consider ART or IVF, for example. And in those patients, we do consider surgery to enhance both pain and chances of a spontaneous conception. I think the quoted increased rates of conception are about 12 surgeries for one additional clinical pregnancy rate.
Mm.
And there's some reasonable observational data coming from the team of Horace Roman in Bordeaux that suggests that effective and high quality surgery to excise rectovaginal endometriosis can enhance spontaneous conception enhance it very, very well amongst those patients with subfertility. So it's certainly a treatment option that we have, but given the risks of surgery associated with deep endometriosis being around 7 to 8% complication rate, I tend to lean more towards IVF, particularly as IVF has a higher chance of them taking home what the person wants, and that's often a baby.
Yes.
But again, you need to balance the suitability of IVF, because for some people, they just can't afford it. It is an expensive program here in the UK.
Yes. And how do you evaluate the tubes, or do you evaluate the tubes for patients who plan fertility preservation? Especially, do you evaluate every patient with endometriosis with hysterosalpingography?
No, not routinely. So if they are having fertility preservation or surgery for endometriosis, then it's just a routine ultrasound and an MRI scan. And I think if there are any concerns detected about tubal disease, then a hycosi would be considered with my fertility colleagues. And if there is tubal blockage, or if there's a hydrosalpinx, then you'd consider perhaps a salpingectomy or a tubal clipping ahead of embryo transfer if they were going for IVF.
In Turkey, we usually prefer doing, if a patient wants to have a child, we usually want to evaluate the tubes with the hysterosalpingogram.
Yeah. Even where the scans don't detect any tubal abnormalities.
Ultrasound scans?
Yeah, so the ultrasound scan or an MRI scan coming to your clinic, that there's no evidence of hydrosalpinx.
Yes. If it's a big hydrosalpinx, we might see it in MRI scan, but it's so expensive in Turkey, the MRI. So hysterosalpingogram is cheaper.
Yeah, certainly. And if patients are, so most commonly patients come to me with desires to improve their pain rather than desires to fall pregnant, as my main specialty or surgical expertise is improving pain. But for those where their primary desire is falling pregnant, they often come directly to my fertility colleagues. And my fertility colleagues, would routinely do a hycosi rather than an HSG to assess tubal patency.
Okay. Okay. My question. We have another question. I'm going to read Martin, okay? From Banu Elmas. Firstly, thanks a lot for your presentation. My question is, does borrowing of fertilized egg get more harder to endometrium with women who had endometriosis surgery before compared to healthy female? Just a minute. Does borrowing of fertilized egg gets more harder to endometrium? Does borrowing of fertilized egg gets more harder to endometrium with women who had endometriosis surgery before compared to healthy female? Did you understand?
Is that about egg collection? The difficulties of oocyte retrieval?
Oh, yes, borrowing. Yeah, probably she's asking for egg collection. Borrowing of fertilized eggs gets more harder.
I don't believe fertilization rates are lower amongst those with endometriosis. Ayla, what's your experience?
No, fertilization rates are not lower.
And implantation rates aren't believed to be lower, certainly not in the absence of a hydrosalpinx.
Yes, but some of the patients with endometriosis have also adenomyosis.
Exactly. Yeah.
Yes, it might affect implantation or increase the risk of miscarriage.
Precisely. And that's something that we don't, well, from my understanding, we don't really know much about what to do for these patients with adenomyosis as well at the same time. There are perhaps some schools of thoughts of, long down regulation for those people with adenomyotic uteri, and I think there are some studies ongoing looking at whether long down regulation changes the modeling within the myometrium and endometrium to enable, higher implantation rates for those people with moderate to severe adenomyosis. But I think there isn't any conclusive evidence at the moment that we can do anything really about treating adenomyosis.
The last question is asked from Dr. John. Okay, John first.
Thank you so much.
Yes, I think, yes, this was our last question. Not Bon. Okay, I'm sorry. Okay, the question was from John. But did we answer your question or understand your question right? Not sure. Okay, good.
Lovely.
Okay. Do you have other comments or?
No, I'd like to thank you for inviting me today. I think it's really important we're having this discussion because certainly historically in the UK, endometriosis is managed, sometimes by gynecologists and then sometimes by fertility specialists. And in those centres where the two teams don't necessarily work side by side, there can be a disconnect in terms of how patients are managed. So I think it's really important that discussions like this are taking place. It's really important that hopefully we're raising awareness of the role of fertility preservation, but being cautious and understanding that fertility preservation isn't going to be necessary for everyone, but for select people, and we're not quite sure of that criteria yet, it could be a really important tool for their future reproductive health. Yes, you're totally right. We should discuss. We should individualize the patients who we are going to do the fertility preservation, and it's not for all the patients. We should consider the family size also. For example, if the patient wants to have children, we should maybe suggest her to plan her next pregnancies if she has endometriosis. Because her ovarian reserve might be lower with also age and with endometriosis. And yes, you're right. Okay, Martin, you have another question again. Yes, thank you for excellent presentation. What do you think about effect of endometrioma aspiration on ovarian reserve? So I think aspiration is likely to temporarily deflate or reduce the size of the ovarian cyst, but without further interventions, it's unlikely to permanently treat that endometrioma. That endometriosis is likely to reoccur, and then the damage that endometrioma will have on the ovary, the oocytes and the ovarian cortex is likely to continue. So I think it's It's certainly not going to be harmful in its own right, perhaps like an ovarian cystectomy, but it will not treat the problem of the endometrioma, and it will potentially not treat the problem that the persistent endometrioma can have, which is a persistent reduction in surrogate markers of ovarian reserve going forward. Someone said they've just had a laparoscopy to remove moderate endometriosis, and she's now pain-free, which is fantastic. I'm really pleased. What can they do to maximize conception? Well, I think tracking your, basic things, tracking your cycles, having intercourse during the fertile window, checking that you're ovulating, making sure that all the kind of conditions are right for you to be able to conceive naturally is important, and ensure that perhaps your partner's had a semen analysis as well.
Okay, Sarah Harris, endometriosis. I cannot see it.
Can pain improve after pregnancy? So pregnancy has a differing role on different people, and for the majority of people that I see, their pain does temporarily get better during pregnancy and then during the period where they're breastfeeding. But then following breastfeeding and the return of menstrual cycles, it's really variable. For some people, they immediately go back to the pain that they were experiencing prior to pregnancy. For some people, they can have prolonged benefit, but it's really, it's one of those conditions that affects different people in different ways. And so unfortunately, I can never guarantee that there'll be prolonged pain improvement. I certainly hope so if you are pregnant.
Okay, the previous question was, I got it in Turkish and I'm going to translate it. After a patient had endometriosis surgery, is it the implantation potential of an embryo is higher in patients who had endometrioma surgery compared to the healthy ones?
So,
surgery, summary, does surgery improve implantation?
Well, surgery improves spontaneous conception. My understanding, surgery does not improve success with IVF or ART, but it does improve spontaneous conception and the ability to conceive naturally. What we spoke about briefly earlier in the presentation is that surgery can have a detrimental effect on ART and stimulation and the number of oocytes collected, but in large-scale analyses hasn't had an effect on clinical pregnancy rate as seen in the Cochrane systematic review. But the positive news is in the review looking at spontaneous conception, there are improvements seen following surgery for endometriosis and endometrioma.
Yes. Okay. I think, yes, we have only 2 minutes. It has been an hour, so the discussion was
perfect time.
Yeah. So
I'd like to thank everyone for their comments and questions. It's been great coming on and speaking this evening.
yes.
And in my presentation, I had a QR code at the very end where people can contact me if they want. And so I would encourage anyone that wants to have any further discussions to get in touch, as we are hoping to try to work towards developing that criteria that I mentioned to you about assessing which patients would benefit most from fertility preservation, particularly in a healthcare service that we work in here in the United Kingdom, which is principally state funded and a small proportion that's privately funded. We need to have a look at cost effectiveness and benefit to the public.
Yes, you're right. It's important, but in Turkey, it's not government funded. But thank you, Martin, for having you. It was perfect, and I really enjoyed the webinar with you. Thank you for accepting our invitation again, and we would like to see you in our conference in March.
Yeah.
Yes, we will definitely want to host you in Turkey, and we want you to see beautiful Turkey.
No, I'd love to too. I'd love
Yes.
to also. So thank you so much for the invitation. And it's been a great pleasure coming on and speaking this evening.
Okay, thank you so much.
Thank you so much.
And I would like to thank everyone who attended our webinar and who sent their questions and just joined the discussion. It was a pleasure to having Martin and all of you. Thank you so much. Bye.